Streptococci and related species. So just thinking about a patient scenario. So the patient's a 9-year-old boy, fever and sore throat over a 3-day period, red pharynx, both tonsils were swollen, pronounced cervical lymphadenopathy, tonsillar swab contents were inoculated on sheep blood agar, small, shiny, translucent colonies showing beta hemolysis. After reading this patient's case history, consider the most likely causative agent based on the presenting symptoms and colony morphology of the isolate. Key tests to be performed on the bacterial isolate for identification, and non-culture assays available to rapidly identify the isolate. So we're going to go through Streptococci and Enterococci and related species. There are a lot of different species that will be mentioned in this slideshow. What I recommend is that you start creating diagrams to track all of the various species and creating those flowcharts showing how different tests will help differentiate the different species will be very helpful. So for your ASCP qualifying exam, it's going to give you a bunch of different questions, and the questions that are released are based on how you answered the previous question. So it'll give you a particular question in a certain category, and if you answer that question correctly, then it'll give you another question from that same category at the next level up. And it keeps challenging and challenging and challenging you until you get a question wrong, and then it'll switch to a different category. Microbiology is just, I believe, 15 to 20% of your overall exam. So kind of keeping this in mind, it's not essential that you memorize every single species of microorganism that could potentially infect a person. But what is important is that you have a general idea of what category these organisms are in. So I recommend making charts or graphs and say these are the Staphylococci and list all the different species of staph, and you can put the coagulase positive ones and the coagulase negative ones. Then you get to the strep and you can say these are all the streps, and you can divide them by either their Lancefield group, which we'll talk a little bit more about the group A, B, C, D, blah blah blah, different types of Lancefield groups, or you can chunk them into like the viridin strep and so forth. So creating these charts that are quick access that you can always reference later on is going to be helpful to know. So for this course, you want to pay attention to the study guide. So I am going to be covering a lot of content throughout this slideshow, but focus on the study guide for what actual questions you're going to be responsible for knowing for this class. The study guide is going to really focus your studying and focus the amount or reduce the amount of content that you'll be responsible for. In other words, I'm going to give you all the information. The study guide is going to give you absolutely what you need to be successful in this course. Okay, so starting off with taxonomy. Numerous changes due to DNA homology and DNA sequencing studies. Formerly Group D is now classified as Enterococcus, and Group N, Streptococci, is now Lactococcus. Lactococcus is different from Lactobacillus. Lactobacillus is your common probiotic that you'd find in yogurt and so forth. Lactococcus is cocci-shaped, not bacillus-shaped. So currently there are 5 genera: Streptococcus, Floricoccus, Lactococcus, Lactovum, and Ocodella. Lancefield classification of the strep. So after recognition of the antigen, or the C carbohydrate polysaccharide, in the cell wall of beta hemolytic streptococci, these streptococci were able to be divided into serological groups designated by letters. So there is a particular carbohydrate on the surface of strep, and that's what we use to categorize them into different groups. Organisms in the A group possess the same antigenic C carbohydrate. Those in the B group possess the same antigenic carbohydrate, and so forth. In general, Streptococci and related species are catalase negative. This is the major distinguishing factor from the staph. So when we learned about staphylococci, we learned that those are predominantly catalase positive. So if you isolate a gram-positive cocci from a patient, you can do a simple catalase test to determine if it's a strep-related or a staph-related species. Weak positive catalase tests may occur when growth is taken from media containing blood. Another distinguishing factor between the strep and the staph is staph means clusters. So usually you're going to see gram-positive cocci under the microscope in clusters or pairs. For the strep means a chain. So if you have strep under the microscope, you're going to see either pairs or chains of gram-positive cocci. So here you can see the gram stain morphology of Streptococci in the various medium. Most of them behave like facultative anaerobes, but they are considered aerotolerant anaerobes. They grow in the presence of oxygen but do not use it for respiration. Carbohydrates are metabolized fermentatively with lactic acid as the major end product. Gas is not produced. Some species are capnophilic, requiring an increased concentration of CO2. So when we're trying to grow, specifically grow strep, we will incubate them in the presence of CO2. Grow best on enriched medium with blood or serum, and colonies are usually small and transparent. So the cell wall structure. So just like any other gram-positive microorganism, we have the cell membrane. Then there's a thick layer of peptidoglycan with teichoic acids. And then you have this group carbohydrate. So this group carbohydrate will put this strep in a particular Landsfield group. So there's group A strep, which causes strep throat. There's group B strep, which causes a lot of issues in neonates and during pregnancy. So based on the group that's found here, this carbohydrate, the group carbohydrate will place it into one of those Landsfield groups. Some species of strep also have a capsule, and we'll talk more about that capsule when we go through the various species. Hemolysis, or hemolysis. Streptococci and similar organisms can produce numerous exotoxins that damage intact red blood cells. Damaged red blood cells form the basis for hemolysis. So the term hemolysis is used to describe the destruction of red blood cells. So hemo, blood, lysis means to break apart or cut up. This should be a review, but the types of hemolysis that you can see, alpha, beta, or gamma, which is also non-hemolytic. So here you can see hemolytic, the beta, versus the alpha. So beta, you're going to see complete clearing, and you're going to see maybe a yellow hue around the growth. And alpha hemolytic, there's incomplete hemolysis, and you're going to see green growing around the colonies. The type of hemolysis is a major distinguishing factor for the various groups. So clinically significant Staphylococcus species. The association of clinically significant Streptococcus species. Association of clinically significant strep and strep-like organisms in disease has been known for more than 100 years. Historically, these organisms were separated into categories as follows. There were the beta hemolytic or pyogenic pus-producing ones, and then the non-beta hemolytic or non-pyogenic ones. Pyogenic refers to fever-inducing, or the ability to cause fever to happen in a person. Use of the term pyogenic streptococci is precise. It contains some species that are not beta hemolytic and some that are beta hemolytic. And some beta hemolytic strep are not part of the pyogenic group. So this is a good table that breaks down the Landsfield group, the hemolysis type, the common terms, and the disease association. I highly recommend that you study this table. So this table has a lot of great information. When you start to put together your flowcharts of how to differentiate the various species, this slide is going to be key with that. So Group A strep. Group A strep, S. pyogenes. Group A Streptococcus, or GAS. So if you see the abbreviation GAS anywhere in the lab or in this course at all, GAS refers to Group A strep. It has an M protein attached to the peptidoglycan of the cell wall and extends to the cell surface. M protein is essential for virulence. It allows for the evasion of phagocytosis. So phagocytosis is cell eating. That's when your immune cells engulf and eat microorganisms. This M protein allows it to not get eaten. There's more than 200 different serotypes and subtypes. Resistance to infection with S. pyogenes appears to be related to the presence of type-specific antibodies to the M protein. M1 serotype is the most common serotype seen in pharyngitis. Products produced by S. pyogenes that have been postulated to play a role in virulence, but the exact role each has an infection is unclear. So there's streptolysin O, S, deoxyribonuclease, streptokinase, hyaluronidase, and erythrogenic exotoxins. Additional virulence factors associated with Group A strep: fibronectin binding protein, or protein F. Hyaluronic acid capsule prevents opsonized phagocytosis by neutrophils or macrophages. It allows the bacterium to mask its antigens and remain unrecognized by its host's immune system. Streptolysin O is responsible for the hemolysis on the blood agar plate. O means oxygen labile. It's only active under anaerobic conditions. It destroys white blood cells, platelets, red blood cells, and other cells. Anti-streptolysin O tests are used to check for recent exposure to S. pyogenes. Streptolysin S responsible for hemolysis seen around the colonies, incubated aerobically. Oxygen stable, can lyse red blood cells and white blood cells. Non-immunogenic, which means it doesn't elicit an immune response. Group A strep caused the lysis of fibrin clots through the action of streptokinase and plasminogen. DNase A through D, all strains of S. pyogenes produce at least one DNase. The most common is DNase B. Hyaluronidase, or spreading factor, is believed to solubilize the ground substance of mammalian connective tissues to allow it to spread deeper into the tissues. Some strains of S. pyogenes cause a red spreading rash known as scarlet fever. It's caused by streptococcal pyrogenic exotoxins, formerly called erythrogenic toxins. These toxins function as superantigens. There's 4 immunologically distinct exotoxin types: SPE, A, B, C, and F. Able to stimulate T lymphocyte proliferation by interaction with class II MHC molecules on antigen-presenting cells, which results in the production of IL-1, or interleukin-1. Clinical infections. Primary sources of transmission are the throat and skin. And examples of infections caused by S. pyogenes: pharyngitis, scarlet fever, pyodermal or skin infections, and other septic infections. So S. pyogenes bacterial pharyngitis, also known as strep throat, most often seen in children between 5 and 15 years of age. It has an incubation period of 1 to 4 days, and then abrupt illness ensues. An incubation period is the time it takes from when the individual actually gets the microorganism until they start to show symptoms of infection with that microorganism. So how long does the microorganism have to incubate or grow in order to start to have symptoms develop in the person? Symptoms start with sore throat, malaise, fever, headache, and the disease varies in intensity and symptoms. Symptoms usually subside in 3 to 5 days unless there's complications. Some ask, well, if I get strep throat once in my life, why don't I have memory cells, and those memory cells protect me against future strep throat infections? And sometimes they tell you, especially with children, that if you don't throw out their toothbrush, they can reinfect themselves and get the infection all over again from that same type of strep. So this has to do with all of the different types that exist. So we talked about 200 different types of strep that exist, and that's the ones that we know of today. So if they get exposed to an immunogenically different subtype of Streptococcus pyogenes, then they don't have the immune memory to protect against that. So you can actually get strep throat multiple times in your life because there's so many different types of S. pyogenes antigens out there. Impetigo is a localized skin disease, small vesicles that progress to weeping lesions, usually found in very young children. Erysipelas is rare. It's a skin infection with spreading rash with a demarcated but irregular edge, mostly found in older adults. Cellulitis is a deep invasion of group A strep leading to necrosis and gangrene. Scarlet fever. Strains that are infected with the temperate bacteriophage T12 produce streptococcal pyrogenic exotoxins. It appears a couple days after bacterial infection. Diffuse red rash that appears in the upper chest and spreads to the trunk and limbs. The rash disappears over the next 5 to 7 days, followed by desquamation, so sloughing off of the external layer of the skin. Infection is characterized by rapidly progressing inflammation and necrosis of the skin. So now we're on necrotizing fasciitis. Necrotizing fasciitis is also sometimes called like flesh-eating disease. So it involves the strep burrowing deep into the skin and causing the skin to open up. So you have large areas of inflammation and necrosis of the skin, and then the skin opens up. Good wound care is a must to minimize the risk of necrotizing fasciitis. Most common serotypes are M1, 3, 12, and 28, characterized as types 1, 2, and 3. Group 2 is only group A strep. Streptococcal toxic shock syndrome. The exact portal of entry is unknown. The entire organ system collapses, leading to death. Initial severe streptococcal infection occurs. Patients often bacteremic and have necrotizing fasciitis. At-risk populations include children, especially those with chickenpox, and older adults. Associated with pyrogenic exotoxin, notably SPEA. The toxins then function as superantigens. The post-strep sequel. So sometimes strep throat and other types of strep infections don't completely go away, and the strep stays around in the body either due to antibiotic resistance or immunodeficiencies or other types of predisposing factors, but the strep can stay in the body and cause severe complications. So if that happens, there's some things that can happen down the road from that. So there's 2 serious complications. One of them is rheumatic fever. It occurs after pharyngitis attacks. Usually begins 1 month after infection. You see inflammation of the joints, heart, blood vessels, and subcutaneous tissues. It can cause serious damage to heart valves, and repeated infections can produce further valve damage. In some instances, antibodies from streptococcal sequel cross-react with the brain to produce a neurologic manifestation of acute rheumatic fever called Sydenham chorea. Rare in most developed countries, remains problematic in developing countries and some poor populations in industrialized countries. Pathogenesis is caused by antigenic cross-reactivity between streptococcal antigens and heart tissue. Acute glomerulonephritis can also occur after pharyngitis or cutaneous infection. Pathogenesis appears to be immunologically mediated. So circulating complexes are found in the plasma of AGN patients. It is postulated that these antigen-antibody complexes deposit in the glomeruli, resulting in kidney damage. So if you remember the structure of the kidney, the main filtration system, where anything that's smaller than a red blood cell basically leaks out of your bloodstream, and then it gets reabsorbed back into circulation if it's a good thing, and it stays in the urine if it's a bad thing. So that happens at that glomerulus. Glomerulus and Bowman's capsule junction. The glomeruli is responsible for, again, filtering out everything we don't want in the blood. And then you have the nephron tubules that reabsorb the stuff that we do still want in the blood. So if antigen-antibody complexes settle in the glomerulus, that can block that and cause acute glomerulonephritis, inflammation of those glomeruli. The drug of choice is penicillin, and we use erythromycin as an alternative. So for group A strep or S. pyogenes specimen collection, swab is rubbed over the posterior pharynx and each tonsil area. If exudate is present, it should also be touched with the swab. Avoid contamination by the tongue and uvula. Recovery, direct gram stain smears are of little value since non-pathogenic gram-positive cocci are part of the normal bacterial biota. So you wouldn't just want to gram stain a swab. You actually have to work up that swab. SBA is inoculated and streaked for isolation, and then there's some selective media that's also used. So SBA containing SMZ improves the recovery of beta hemolytic strep from throat cultures. Observed after 24 hours, 35 degrees Celsius ambient or anaerobic or ambient air conditions for the presence of beta hemolytic colonies. If none, incubate for an additional 24 hours. False negative results can occur from an overgrowth of normal biota and lack of beta hemolysis. On blood agar plate, GAS are small, transparent, and smooth with a well-defined area of beta hemolysis. So in the previous slide, it can go unnoticed. There's certain strains that may not be beta hemolytic, and if it's not beta hemolytic, then the tech would not know that it's there. So usually on throat cultures, that's what we're looking for, is that clear zone of beta hemolysis around the growth. Gram stain smear reveals gram-positive cocci with some short chains. Suspected colonies can be examined further via Lancefield typing using serological methods, rapid identification, and biochemical methods. Key traditional tests for throat specimens: bacitracin susceptibility or pyrrolidinol alpha-naphthalene naphthalamide PYR hydrolysis. GAS is susceptible to bacitracin and hydrolyzes PYR. Most other groups are bacitracin resistant and PYR negative. It's important to differentiate group C and G strep from GAS with Lancefield typing. For specimens other than the throat, hippurate hydrolysis, Christie-Atkins, Munch-Peterson, Camp test, bile esculin test, 6.5% sodium chloride broth, rapid detection tests for the detection of GAS in throat swabs. There's enzyme immunoassays, optical immunoassays, or rapid PCR tests available. And then there's several commercialized systems to detect from blood cultures. So this is a table that shows you susceptibility to various antibiotics and the group kind of broken down here. This is another good table to review when creating your flowcharts to differentiate the different species. So switching gears to group B strep or strep algalactiae. So this possesses the group B specific antigen, acid-stable polysaccharide in the cell wall, also known as group B Streptococcus. There's 9 recognized capsular polysaccharide serotypes. The capsule prevents phagocytosis but is ineffective after opsonization. So if It's opsonized if antibody coats it, or if it's coated by complement, then the capsule is deemed ineffective. Sialic acid is the most significant component of the capsule and critical virulence determinant. Studies with mutant strains showed loss of capsular sialic acid was associated with loss of virulence. Products produced by S-algalactate are Group B: hemolysin, camp factor, neuraminidase, DNases, hyaluronidase, and protease. There's no evidence that any of these products plays a role in virulence. Significant cause of invasive disease in newborns. So it's known as the leading cause of death in infants in the United States, even though the incidence decreased dramatically from 1990s to 2008. If a mother is getting close to the end of the pregnancy, she must be screened for Group B strep. To screen for Group B strep, a swab goes around the vulva of the vagina and around the anus, and then we would inoculate that into some type of Group B strep broth, like Lim broth or Todd Hewitt broth, and then that broth would be incubated, and we usually do molecular testing directly on that broth. If the mother is positive, then that means that the mother would be strongly or highly encouraged to take antibiotics, usually through IV antibiotic therapy, throughout the entire delivery process. So if it's going to, especially if it's going to be like a natural birth, when the water breaks, the baby all of a sudden or suddenly becomes at risk for getting that Group B strep infection. So the mom gets treated with antibiotics throughout the delivery. So she's got an IV antibiotic drip through the delivery, and then the baby is immediately treated with antibiotics after the delivery. Sometimes mothers can forego screening. They don't get health care, they don't get screened, and then the baby's born and they can get this infection. About like 30% of women are naturally carriers for this, so if you don't get screened, there's a high risk to the baby getting that infection, and then the baby can get respiratory infections, meningitis, brain infections, and have lifelong disabilities or even die from this infection. So it's really important to screen and treat the baby. Sometimes physicians will, if the mother hasn't been screened, they'll just treat the baby with antibiotics regardless, so that it reduces the risk of the baby getting sick. Early onset of infection, so less than 7 days old. 80% of cases are vertical transmission from the mother during the birth. Premature birth, membrane rupture, develops into pneumonia or meningitis with bacteremia. Late onset infection, 1 week to 3 months after birth, it can be meningitis. The mortality rate is of serious concern. Death occurs if treatment is not started immediately. Adult infections, mother after childbirth or abortion, can cause endometriosis or wound infections, and even endocarditis. In older adults, there's immunodeficiency, skin and soft tissue infections, intra-abdominal abscesses, bacteremia, pneumonia. The drug of choice is penicillin. Clindamycin can be used as a backup drug. On SBA, S-algalactate is grayish-white mucoid colonies surrounded by a small zone of beta hemolysis. Gram-positive cocci in chains, short chains in clinical specimens, longer chains in culture. Presumptive ID is based on antigen detection or biochemical reactions. More often than not, we're just doing a PCR or rapid DNA type test to identify S-algalactate. So here you can see the small zone of beta hemolysis, and then there's a really helpful flow chart that can help differentiate the different streps here. So again, in pregnant women, that screening happens at 35 to 37 weeks gestation. Inoculate to selected broths such as Todd Hewitt broth with antimicrobials, Lim, transvag broth, there's strep B carrot broth. Subculture it to SBA. Numerous nucleic acid amplification tests for non-enriched clinical specimens and culture-enriched specimens are available. Universal vaginal and rectal screening of all pregnant females late third trimester. Screen pregnant women with asymptomatic bacteria prophylactic antimicrobial therapy for women whose samples test positive. So again, that's giving the mother the antibiotics while she's about to go into labor. So if they have vaginal and rectal screenings positive, urine culture was positive, if they have a previous history of group B strep, or if we just don't know if they have group B strep or not, they haven't been screened previously, then we recommend taking antibiotics. Group C and G strep, beta hemolytic large colony isolates. Small colony isolates can be the S. anginosus group. S. pneumoniae, also known as the pneumococcus. So if you've heard of the pneumococcal vaccine, this is what it's vaccinating against. It's isolated from a variety of clinical specimens. It is a member of the S. mitis group. Cell wall contains an antigen called C substance that is similar to the C carbohydrate of various Lancefield groups. C-reactive protein, a beta globulin in human serum, reacts with C substance to form a precipitate. So CRP increases during inflammation and infection. S. pneumoniae can express one of 90 different capsular types based on chemical variations of the capsular polysaccharide. Antibody detection against the capsular antigen is protective. The capsule is antigenic and can be identified with appropriate antisera. So that capsule is a major protective factor. It also makes colonies that are growing look kind of slimy and mucoid. Strains without a capsule are non-pathogenic, so they don't cause disease. There are several different toxins that are produced, but none of these toxins have shown to have a role in disease production. So it can cause pneumonia, sinusitis, otitis, which is an ear infection, bacteremia, and meningitis. There are over 100 capsular serotypes. Conditions required for developing pneumococcal pneumonia: the organism must be present in the naropharynx, nasopharynx, and individuals must be deficient in specific circulating antibodies against the capsular type of the colonizing strain of S. pneumo. After colonization, the bacteria can persist for weeks or months without causing disease. In some individuals, invasive disease occurs that leads to community-acquired pneumonia. Usually occurs as a result of the disturbance of the normal defense barriers, not a primary infection. Predisposing conditions: alcoholism, anesthesia, malnutrition, viral infections of the upper respiratory tract, or age. Older adults are at increased risk. This is why it's strongly encouraged that older adults get that pneumococcal vaccine. Infection begins with an aspiration of respiratory secretions, which often contain pneumococci. The infecting organism in the alveoli stimulate an outpouring of fluid that serves to facilitate the spread of the organism to adjacent alveoli. The process stops when the fluid reaches fibrous septae that separate the major lung lobes. Pneumococcal or lobar pneumoniae, chills, cough, dyspnea, which is shortness of breath. Pneumonia may be complicated by pleural effusion that is usually sterile. S. pneumo can also be involved in endocarditis or peritonitis. Endocarditis is inflammation of the inner lining of the heart. Peritonitis is inflammation of the abdominal wall, the peritoneal fluid surrounding the abdominal organs. Bacteremia often occurs during the course of a serious infection. Consequently, samples for blood culture are often taken simultaneously with sputum or fluid aspirate. There are 2 types of pneumococcal vaccines that are available. You just need to know that a vaccine exists. Laboratory diagnosis characteristic gram-positive diplococci with lancet shape in pairs or short chains. As the culture ages, so as it sits longer, the gram stain reaction becomes variable, and a capsule stain can reveal the capsule. Culture, complex media is required, so brain heart infusion, tryptocase soy agar with 5% sheep blood, in other words, SBA, chocolate agar. Some strains need increased CO2 concentration for growth during the primary isolation. Isolates produce a typical large zone of alpha homolysis on blood agar surrounding the colonies. Young cultures, round, glistening, wet, mucoid, dome-shaped appearance. As the colonies get older, autolytic changes result in the collapse of each colony center, giving it the appearance of a coin with a raised rim. So this is a picture of it under the microscope, and then here's a picture of the colonies. How to distinguish S. pneumoniae from the viridin strep. So colonies may look very similar. Techniques to distinguish them include optochin susceptibility, bile solubility test. So S. pneumoniae is bile soluble. Other alpha hemolytic species are not bile soluble. Then there's some rapid tests that exist. Antimicrobial resistance, so penicillin remains the drug of choice even though there is some resistance. Resistance is caused by altered penicillin binding proteins. When penicillin is resistant, other classes of antimicrobials show resistance as well. So the beta-lactams, macrolides, tetracyclines. Resistance to extended spectrum cephalosporins has increased but can still be used to treat serious infections. Multi-drug resistant strains occur, and they're defined as being resistant to 2 or more classes of antimicrobials, and it can occur in the presence or absence of penicillin resistance. The viridin strep. This is normal biota of the upper respiratory tract, female genital tract, and gastrointestinal tract. Viridins means green. Many show alpha hemolysis. They're fastidious, with some requiring carbon dioxide. Viridin strep has more than 30 species in 5 groups: the S. mitis, mutans, salivarius, bovis, and aeruginosus groups. S. bovis belongs to group D strep, possess the group D antigen. S. bovis, though, is no longer a valid species name. DNA studies found that S. bovis and S. equinus are the same. S. equinus was adopted as the new name for both. Now all human isolates of S. bovis are identical, assuming the name S. galolyticus. Group D strep historically has 2 groups, the enterococcal group and the non-enterococcal group, and these can be differentiated by the sodium chloride. So the enterococcal groups are bile positive, but they grow in 6.5% sodium chloride. The non-enterococcal are bile positive, but they do not grow in 6.5% sodium chloride. More is known about the molecular characteristics of the 2 groups. Oropharyngeal commensals that are considered opportunistic pathogens. Virulence is low, but they can cause disease if the host defenses are compromised. Most common cause of subacute bacterial endocarditis. Bacteremia is more common in children than in adults, more prevalent in patients with hematologic malignancies. The course of endocarditis is slow. Individuals whose heart valves have been damaged by rheumatic fever are especially susceptible to endocarditis from viridin strep. Other types of infections: gingivitis, tooth decay, meningitis, abscesses, osteomyelitis, and epiema. Most are penicillin susceptible. Some resistant strains have been reported. The virulence factors have not been well established. There's a polysaccharide capsule and cytolysine that have been identified in some members of the S. aeruginosus group. Other factors with possible virulence tendencies include the extracellular dextrans, cell surface associated proteins, and extracellular enzymes. It's extremely difficult to identify isolates in the laboratory. Laboratories should be satisfied to place isolates in one of the 5 groups. Typical characteristics on gram stain smears: there are some plates on the microscan that you can use. There's a strep-specific plate that can differentiate different types of streptococci. The lack of beta hemolysis separates the viridin strep from the groups A, B, C, and G. Differentiate alpha hemolytic strep from S. pneumoniae, also alpha hemolytic based on optocin sensitivity, biosolubility, and anticapsular antibody tests. Tests to differentiate the species within the viridins group, the VP test, hippurate hydrolysis. There's also multi-test kits that are available. And this gives you kind of a further breakdown of other tests that can be used. So general characteristics of enterococci, these are natural inhabitants of the intestinal tract. Two most common species are E. faecalis and E. faecium. All species produce a D antigen and belong to the Lancefield group D. Weak bubbling in catalase test and can grow under extreme conditions like bile salt or alkaline pH. The development of molecular methods, the MALDI, multi-locus sequencing analysis, may be used for identification. And this is another good schematic that you can use when creating your own flowcharts for differentiating the species. Virulence factors that contribute to pathogenicity are incompletely understood, so can grow in extreme conditions, and it's resistant to multiple antimicrobial agents. One of the big ones that it's resistant to is vancomycin. So there's vancomycin-resistant enterococci, VRE. VRE is known to be highly contagious and spread that resistance to vancomycin to neighboring species. So that is a major concern when that's reported. There are some possible virulence factors of E. faecalis that may play a role in colonization and adherence to heart valves and renal epithelial cells. E. faecalis also produces a 2-subunit toxin termed cytolysin. Nosocomial or hospital-acquired infections. Urinary tract infection is most common, often associated with urinary catheterization or other urologic manipulations. Prolonged hospitalization, bacteremia may occur, and endocarditis accounts for 5 to 10% of bacterial endocarditis is associated with Enterococcus. Standard collection and handling procedures. Specimens should be cultured right away. Streptococci, soy, or BHI agar supplemented with blood. Organisms grow well at 35°C in the presence of carbon dioxide. Selective media can be used if clinical specimen is obtained from contaminated site or multiple microorganisms are likely. And this is a picture of Enterococci on blood agar. Biochemical tests are available, and there's commercially available kits that can help identify it. Resistance, as I mentioned, that vancomycin-resistant enterococci is of major concern. There are 2 genes that are most frequently encountered, VAN-A and VAN-B. PCR-based assays have been used to detect VRE. Streptococcus-like organisms, Aerococcus, Gamella, Lactococcus, Leuconostoc, and Pediococcus. Aerococcus is one that I've seen clinically in urine specimens a lot. Lactococcus I've seen in fecal cultures as usually just like a commensal or an opportunistic type organism. Abiotrophia and Granulocytella. Bacteria grow as satellite colonies, so you have the primary colony, and then you'll see these tiny colonies growing around the primary colony. This is part of the normal human oral and gastrointestinal microbiota, but it can be a significant cause of bacteremia, endocarditis, and otitis media. Aerococcus, common airborne organism. Opportunistic pathogen that can cause bacteremia, endocarditis, and UTIs in immunocompromised patients. It resembles viridin strep on culture. So when we do a urine culture, if we see a alpha hemolytic organism, even if there's not that many of them, we kind of take a closer look at them and work them up and identify them on the MALDI. There are additional genre in or species within the genre, Dolosiosis and Glabecatiella, and these species are related as they're catalase negative. They can be isolated and cause infection in certain cases. Again, the more important thing here is to just be familiar with the names. So create a table, put some of the names in groups where they belong, however you want to organize this information and group them. And then if you do happen to see a test question on this on your qualifying exam, you may be able to kind of remember where it was grouped on a table that you created at some point. These are pretty rare and they probably won't come up on that qualifying exam, but it's good to just kind of be familiar with the fact that they exist. These also, same thing. Lactococcus, I did see this one isolated from a respiratory culture once, and this one was an interesting case because it was misidentified, and then once it was finally identified, it became a major concern for this patient. So gram-positive cocci appear singly in pairs or in chains, physiologically similar to enterococci, either alpha hemolytic or non-hemolytic, previously classified as group N strep, associated with UTI and endocarditis. Microorganisms do not react with the genetic probe in AccuProbe enterococcus culture confirmation test. Here's another species. Have never encountered this clinically, but it may pop up in UTIs. And you can see the morphology kind of looks more like staph instead of strep. However, it's catalase negative. Pediococcus, arranged in tetrads, pairs, and clusters, and it can grow at really high temperatures. It resembles the viridin strep. It's intrinsically resistant to vancomycin. Vagococcus is another one of those that can be identified in the MALDI-TOF, but has very little clinical significance. It's found more in animals. So going through a summary of the laboratory diagnosis of the Streptococci and related species. Classification schemes include the hemolytic pattern on SBA, physiological characteristics, and surface typing. And then there's biochemical characteristics. So this classification divides the strep species into 4 groups. Pyogenic strep. These are the ones that produce pus. They cause fever. They're mostly beta hemolytic and constitute most of the Lancefield groups. Lactococci are non-hemolytic, Lancefield group N antigen, often found in dairy products. Enterococci, part of the normal intestinal biota. And viridin strep, widely found in URT or upper respiratory tract. The Lancefield classification scheme, most commonly used scheme. The system is based on extraction of C carbohydrate from the streptococcal cell, and it's achieved by placing organisms in dilute acid and heating for 10 minutes. The soluble antigen is used to immunize rabbits to obtain anti-sera to the various C carbohydrate groups. Biochemical identification. Hemolytic reaction of the isolate determines which select identification test should be done. Exhaustive testing is not always needed. So this shows the biochemical identification, another really good chart to help you identify your flow chart, differentiating these various species. This is a rapid strep panel from Remmel. It'll change different colors in the presence of different metabolites. Bacitracin susceptibility can also be used. It's used as a presumptive test for S. pyogenes. It's helpful for screening group A strep in throat cultures. The CAMP test. CAMP is an acronym derived from the first letters of the surnames of the individuals who first described the reaction. Camp, Atkins, Munch, Peterson. 3 ways to perform the test. Use beta-lysine producing Staph aureus, use a disc impregnated with beta-lysine, or you do the rapid CAMP test. It detects the production of enhanced hemolysis. Occurs when beta-lysines come in contact with the hemolysins of group B strep. May use purified beta-lysine on confluent Streptococcus colony. Discs containing beta-lysine also work. So here you can see we've got the staph, we've got group B strep, and then it will form this arrowhead of hemolysis. The rapid CAMP test looks like this. Hippurate hydrolysis differentiates group B strep from other beta hemolytic strep. Group B strep possesses the enzyme hippuricase, or hippurate hydrolase, which hydrolyzes sodium hippurate, forming sodium benzoate and glycine. A rapid 2-hour test is available. PYR test, the presumptive identification of group A strep and non-hemolytic enterococci. Group A strep is the only strep that is PYR positive. Other PYR positive genera include Enterococcus, Aerococcus, and Gamilla. This is just some more information about the PYR test. And positive would turn pink on this disc. Leucine aminopeptidase is another test. I have never seen this performed clinically, but this is another test that you can read through. And it helps differentiate Aerococcus and Leuconostomus species from other gram-positive cocci. The VP test I've seen more commonly with enteric pathogens. And you can read a bit more about this test. The BGUR test detects the action of beta-glucuronidase, enzyme found in isolates of large colony forming group C and group G beta hemolytic streptococci. Commercially prepared rapid assays are available for this. The bile-esculin test. Bile-esculin hydrolysis tests for the ability to grow in 40% bile and hydrolyze esculin, and that's features that are found in group D strep. So Enterococcus are positive and group D strep are positive. The salt tolerance test, so whether or not it can grow in 6.5% sodium chloride, differentiates the group D from the Enterococci. So Enterococci can grow in it, group D does not. Optochin susceptibility, so this is the P disc. You add the disc to the surface of the SBA plate, incubate it, and then you can presumptively identify S. pneumo. So here you can see susceptible S. pneumo. Here's resistant. Immunoassays also exist for the diagnosis of this. So direct clinical specimens like the throat swab, we can use antibodies to detect. There's latex agglutination, slide agglutination, enzyme-linked immunosorbent assays that are available. There's a slide agglutination test for the Lancefield groups. So you can see A, B, C, D, F, G. And there's probes that exist for select species such as the pneumococcus. Susceptibility testing, penicillin is the drug of choice. If penicillin isn't working, then susceptibility testing may be ordered. Possible alternate choices are erythromycin and narrow-spectrum, cephalosporins. Multi-drug resistant strains of S. pneumo have been reported, and then vancomycin resistance is increasing.